Good morning to everyone. First of all, I'm very glad to be here, and I'd like to bring the greetings of Professor Massimo Sangiorgi from Structural Disease in Tor Vergata Hospital University, with whom I have the privilege of working every way. Today, I am the opportunity of sharing with you some personal reflection about structural cardiologists in 2026. You know, 10 years ago, we debate about whether TAVI can compete with surgery, if the procedures were effective. But now I think we have to change paradigm, we change mindfulness, and to change our personal quotient. So we have to change our paradigm. The correct question is, can we do it? So can we perform TAVI, or which lifetime strategy is best for this patient? Structural cardiologist today has crossed an important threshold. The persevere feasibility is no longer like the main challenge. I think that lifetime management and the right time for right patient and the right device and the right correct lifetime management is the central thesis of this discussion. So we know let's begin with TAVI for sure. You know that TAVI in a low risk patient today is a possibility, because you know the results of the most important trial in low risk patient. For example, partner 3 in balloon expandable valve that demonstrates a similar composite endpoint of death, stroke, major stroke, and hospitalization between this platform and the surgery. On the other hand, Evolo low risk trial demonstrated that the results, the outcome, and the composite MACE results are excellent, and the valve performance and the hemodynamical performance is good at 5 years. But you know that self-expandable valve are sometimes complicated by pacemaker implantation, and I think that this is clinically meaningful, because if we treat a 63, 65 patient, you have to take in mind this possibility. And you know that yes, the trial are provide reassurance, not centrality, So, as the feasibility of TAVI in TAVI at scale is not designed in this trial. For example, the trials have to give answer to, for example, obstruction risk, residual gradient, and the long-term performance of the second valve. So, you know, the first valve is only the first chapter. For example, the coronary access outcomes, you know, the most important studies about realign, align trial from Tarantini et al. So we have to plan very attentively this our first procedure, and you have take in mind the very long-term durability, because you know that surgical bioprosthesis have decades of follow-up. TAVI, no, we can speak about 10, 15 years, so we have to speak in the next trials about subclinical thrombosis, about alprosis, about stress of the leaflet, about subclinical thrombosis. And on the other hand, end, we have some differences about sex and anatomy durability. We know that, for example, the women have a small annulus, have a small vasculature, and from an anatomopathological point of view, for example, the Mariano demonstrated more fibrosis in this valve in comparison with the calcified valve. You know that bicuspid anatomy and a large annulus are underrepresented in a pivotal trial. But the other scenario that we have to treat in this review, in my opinion, is the cohort of asymptomatic severe aortic stenosis. In the past, our mind was wait and see. Now is no longer passive surveillance, because early TAV demonstrated that this procedure reduces significantly the compensate of death, stroke, and unplanned cardiovascular hospitalization. On the other hand, other trials like Avatar and Recovery on surgical cohort demonstrating showed clear the same results. So our procedure, our planning has to stratify our patient by many tools, for example, exercise stress testing, biomarkers, for example, BNP, proBNP, and global longitudinal strains to detect subclinical systolic dysfunction, score calcium, you know, the values that are different between human women and males, and of course the clinical suspicion when there is a rapid progression and increase at serial echocardiography. So the lifetime management, in my opinion, is the new TAVI paradigm, and begins first of all from a great art team discussion, because you know art team is first of all a team coaching, a collaboration between different figures like cardiac surgeon, cardiologic anesthesiologist, because there is always the imager, the cardiac imager in cath lab too. So we have to speak about in our team, in our outpatient clinic of frailty, pre-frailty. So we have to deal with these skills. We have to discuss when we see this patient about life expectancy, anatomical assessment, especially in low risk and asymptomatic patient, and the future planning, because you know the TAVI lasts 1 hour, but the consequence of this procedure can last 20 years. So we have to deal with these topics in the past, and our team for me is the center, is the mantra, because it is a mean of multidisciplinary approach that can permit some specified protocol for nursing. You know that the TAVI coordinator is most important in our planning of TAVI. Heart failure specialist or electrophysiology, you know that, for example, left atrial occlusion appendage from option trial is not is being considered in ablation of atrial fibrillation workup. So assess life expectancy, the coronary computed tomography analysis is very important for neosinus commissural orientation, for previewing the TAVI in TAVI in the next, and document coronary reaccess feasibility in cath lab at the first TAVI. But we move on because we are late on mitral edge-to-edge strategy. You know that from this trial, for example, oh sorry, no, okay. Okay, the coapt and mitra FR reshape and clasp to do someone can think that they are contradictory, but the trial has underlined that the problem is differentiated proportionate versus disproportionate mitral regurgitation, because mitral FR deal with a patient with dilated left ventricle, and sometimes with the patient that not treated with good medical therapy. So for the future, the most important thing is the phenotyping of this patient, as coapt 5 years and reshape heart failure and clasp 2 in Pascal procedure clearly show. So the sorry, what's the problem? Maybe here. Okay. It's okay. Sorry. So the ideal candidate for mitral clip or Pascal procedure is a patient with a ROA more than 0.3 centimeter square, with the disproportionate mitral regurgitation confirmed, left ventricle and diastolic volume index minus 96 milliliter for meter, and a good medical therapy, functional MRI phenotype driving the heart failure syndrome, and class NIA 2 or 3. We have to arrive at the right time, because sometimes mitral regurgitation is only a bystander, is not the driver of the disease of disease of this patient. First of all, in patient with annular dilatation, for example, and for sure we have to deal with the tricuspid intervention that was in the past the forgotten valve. Today, I think is the most exploding area in structural intervention, and is very exciting, because in this case too, you have to profile to shaping our patient, and as demonstrated by Triluminate and Trisend in evoke replacement, the timing, the planning is very important, because the trial demonstrating an improvement of quality of life and a reduction of tricuspid regurgitation, evoke and demonstrated again a near complete tricuspid regurgitation, but we can deal with the problems of lifelong anticoagulation with this valve, adaptation or right ventricle. So if we have pulmonary hypertension and a failure of right ventricle, we have to assess very well this patient for deciding if tricuspid intervention is good for our patient or not. So the sorry. Okay. So the selection criteria in this case is important too, because we have to treat a patient with a symptomatic severe tricuspid regurgitation despite optimal medical therapy, for sure preserved or mildly reduced right ventricle function, no severity pulmonary hypertension, and anatomy within a device range, and absence, for me this is very important, of severe cardiorenal syndrome or end organ failure, because sometimes we risk to treat some patient that is at the last stage of disease. I move on left atrial appendage closure, and we know that today this procedure is beyond the last resort in patients that are intolerant or cannot take novel anticoagulation. You know that Prague 17 and the results at 4 years demonstrated that this procedure is non-inferior to novel anticoagulation. Option trial demonstrated that this procedure is very important as planned strategy in patients treated with ablation procedure. Amulet and Swiss upper però demonstrate the feasibility and the non-inferiority of this device with the novel anticoagulation. Champion atrial fibrillation with the Watson Flex is the most important trial about the feasibility of this device in these candidates to this procedure. So the ideal candidate, but I think we speak about this topic in the morning and the afternoon, is high thromboembolic risk, high bleeding risk, prior major bleeding, and a suitable left atrial appendage anatomy. My last topic, patent for anormal closure. You know that today is a mature therapy, but we have to consider that the neurologist, for example, partnership is not optional, is the foundation of every decision. So respect, close, reduce, and first, especially defense PFO demonstrated that when we have high risk morphology, for example, atrial septal aneurysm and hypermorbidity of septal aneurysm, this patient maybe benefits more from this procedure. So for concluding, today we have the possibility of having an advanced planning and imaging with the computed tomography, with the possibility of fusion of intraprocedural transesophageal echocardiography, ICE, and we have the instrument of artificial intelligence in a mixed reality. But I think that the clinical judgment is the key. So our team and the collaboration between different partnership is very, very crucial. So TAVI is a mature procedure, but lifetime management is the new frontier in this topic. Mitral edge-to-edge therapy works, but the patient selection, the patient profile, the patient phenotyping is everything. Tricuspid intervention is the most exciting, the most exploding area in this last year, but I think that the profiling of this patient and the timing of our procedure is crucial. For left atrial appendage, we know that we moved beyond the bleeding contraindication area, and we know that we are not only implant a valve, a clip, but we treat patient. So the decision we make today will determine the option of our patient in 2036. And as Patch Adams' speech to medicine student was the father of clown therapy, if we treat a disease, you can win, or lose. But if we take care of a patient, we always win. So thank you very much, and I would like with this mantra, leave you with this mantra, that technology opens possibility, but judgment determines outcome. So never always remember that we are, first of all, some doctors, not only technologists. Thanks a lot.
Thank you, Dr. Mariano. So this was a kickstart. It was an amazing summary of all the things that some of the pioneers in the field have worked on for so many years. So, Arik, what's your take on that? So we always talk about lifetime management and how to properly select patients and implement the best procedure for the best patient, but also to have the right timing, right?
Thank you. Wonderful.
Thanks.
I think you concluded with the perfect sentence, and this is definitely the bottom line of my experience. I think that TAVR, I wrote it in my lecture, TAVR gave birth to the rest of structural transcatheter interventions. And I think that from TAVR we should learn so much regarding the mistakes that we were doing. And you know, I always tell that I hoped for a long time that transcatheter mitral valve replacement will stay for a long time not transfemoral, because this is the only way that the surgeons will need to do it, and will do it together.
Yeah.
So I think that learning from what we have done with TAVR and trying to do it with the other structural intervention will be the best thing we can do in order to go the right way.
Yes, for me it's a mantra. I think the collaboration and first of all the patient in front of us deserves our attention. So it's not okay, implant TAVI, but today, you know, low risk patient, asymptomatic patient, patient 65. I have to stress the planning of first TAVI, because it's the first chapter, and it's very important to collaborate with other clinicians, because we can take together the good decision for our patient.
Yes, and I think heart team is very important on this topic. You're right. So we shouldn't at least trust our gut. We have to as Dr. Mariano projected, we have to have a thorough discussion about the patient, about the possibilities, the long-term possibilities. And when we plan the first valve, we should always pay special attention to what will happen down the line.
Yeah.
So we're not kicking the can. We need to maybe to also in the first place try to implement the therapy for the second valve as well, right?
I think you're absolutely right. The only problem is that heart team, which is definitely the most important part of this journey, but the heart team should be a real heart team.
Yeah.
Not the way it's being done in the vast majority of centers.
Sometimes it's a formality or nothing.
No. The problem is that heart team should be without the interest of the heart team. Heart team should be as we write the patient in the center. And as long as the patient will not be really in the center and each one will try to pull to his side, it will not be a heart team.
Yes.
So I think, yes, heart team is very, very important, but it should be done accordingly and the right way.
Yes, this is exactly what all the people that they're part of the heart team, they always had to take, you know, to take into account every time. So, and the last question, you showed very elegantly that we have the possibility of expansion of the indications for TAVI, for instance. So we have the early TAVI, the TAVI unload. Maybe, of course, the surgical study, the Avatar. Do you see that there will be some change in the guidelines in the near future, or we should wait?
Okay, I think so that we can have some change in guidelines, but I think in the concept of TAVI we have to be very, very wise, because now we can perform a TAVI in less than more than 17 years, but sometimes we don't remember that in bicuspid anatomy, in transfemoral anatomy, and on the other hand, we have to convince our clinician, our clinical cardiologist, that sometimes a patient that is asymptomatic, if you perform BNP or you perform stress echocardiography, the patient can, the active listening to our patient, the patient report breathless, okay? And so I wait for changing guidelines in the future in asymptomatic and low-risk patient, yes, but we have to perform a great job altogether.
To properly identify the, with the collaboration, the proper patients, and provide the better therapy in a timely manner. So thank you. It was an amazing talk, and